Hello there. Good evening. Well, looks like we've got a little issue here on New Life Fertilities, but my name is Dr. Randy Fink, and happy evening to you. I am so glad to see everybody here. Hi, Rosa. Hi, Megan. Hope it's going okay. Hey, folks. Dr. Randy Fink, and you are on Fertility with Fink, the one place that you need to be every Tuesday evening at 5 p.m. Central Time, which means 6 o'clock on the East, 4 o'clock in the mountains, and 3 o'clock on the West Coast. I'm the fertility gynecologist here at New Life Fertility in Pensacola, Florida, and I am happy to be here as we are every week to talk about all those things that are important to you. And that's things about making your family, making the dream come true. It's been quite a week, quite a nice weekend. Last week, I was in one of our satellite offices, um, I was in Dothan, Alabama. I was in Panama City in our Tallahassee office, and we're always happy to. I have great staff. We have great staff in those places, and more importantly, really get to meet some great people in areas that are just beautiful parts of these United States. I'm lucky enough that I get to see folks from really all 50 states who will consult with me and come here to see us in Pensacola, and we are very happy to be of service to you. Hey, Angela, nice to see you, and happy Tuesday. Megan, thank you so much. Oh, Simona is with us from Panama City, so she just heard me say about how wonderful our staff is in Panama City. Simona is that staff extraordinaire. There are a wonderful nurse practitioner, nurse midwife in Panama City who is here to help you make your family. We've got a couple of different feeds. Let's say hi to Cowser. Hello, thank you for being here. And to Sarah, Mrs. Villarreal, thank you. My dear friend Angelina Foxy in the beautiful state of, well, we'll say, shall we say Missouri? Shall we say Montana? One of those M states, Michigan, one of those M states up there. Mrs. Villarreal says, hope you like your new clinic. I sure do. Hey to Victoria, Bryn Chaka, and it looks like Lelix3. Nice to see you. Rose, appreciate you saying so. If we try to get to all your questions here during the next hour, we'll be here for the until top of the hour. If for some reason I can't get to your questions, by all means, please email them and we will take them at the top of the show next time. And that is askfertilitywithfink@firstfertility.com. That's askfertilitywithfink@firstfertility.com. We do have one of those questions from last week. And Marjorie asks, does my husband really need to do a semen analysis? And the answer to that is yes. Why is that? Well, the answer is that in up to, we say 40 to 50% of the cases, there is a male factor involved with infertility. So we don't just conclude that it's a problem with the woman. The problem is with the couple, and particularly in really up to half the cases, we find there is an issue with the sperm. What do we look at with sperm? We look at the sperm count. We look at the motility, which is the number of sperm that are swimming. And we look at at what we call the morphology of the sperm. Morphology means that a sperm has a head, it has a neck, and it has a tail. And somebody can look under the microscope and tell us what percentage of those sperm are actually normal. And what's really most interesting is that in human males, 96% of our sperm are abnormal, and that's normal. Now, there are a lot of women out there who would say, that's no surprise to us that 96% of your sperm are abnormal. But what's normal is that 4% of the sperm look normal. And so that's called morphology. We're able to look at the sperm and determine how many of them, how many are swimming, and really how they look. And that gives us clues into how they will fertilize your eggs. So does your husband really need to do the semen analysis? And the answer is yes. In most cases, we really don't want to treat you until we know that the sperm are going in the right direction. Now, most men do not love having to do a semen analysis. And how does that work here at New Life Fertility? Well, there are some places where you go and there's actually a collection room, and you go in that room and you collect the semen sample. At New Life, we give you the cup, and you collect that sperm at home and you bring it into our office. Now, if you are in one of our satellites, so that's Dothan, Panama City, or Tallahassee, we have certain days that there is a courier that will rapidly bring that semen specimen to our lab here in Pensacola for evaluation. And that's really how a semen analysis is performed. Not a difficult test to do, but still really a very important test. Thank you for your question. We appreciate that. Remember, if we don't get to your questions here, ask Fertility with Fink at firstfertility.com. So Rosa says, I have a 2.5 centimeter subchorionic hematoma that bled massively at 8 weeks. I'm currently at 15 weeks and no bleeding since then. Can I resume light gym activities and resume the baby aspirin? I was on Lovenox until about 8 weeks. So a subchorionic hematoma is a collection of blood that lives underneath the placenta. It's very common. It's very common to find in early pregnancy. We know that really 1 out of every 2 pregnancies will have some bleeding in the first trimester, and a subchorionic hematoma is really one of the reasons. Most of the time, just like any bruise that you may have on your skin, that hematoma resolves. So imagine if you were to punch me in the arm. Let's say you give me a good punch in the arm and it turns all black and blue, right? Well, so over time, the body starts to break down that clot that's underneath that little collection of blood, and it starts to turn different colors. So it goes from kind of black and blue to being sort of pale and greenish yellow as the blood that's collected underneath starts to go away. And that same thing will really happen at the level of the placenta, but there is always a little exit door at the placenta, and that is to leave through the cervix. And that's why some of that blood will come out, and that's why you see the bleeding. Most of the time, Rosa, a subchorionic hemorrhage has resolved by the time you're 15 or 16 weeks. So my guess is, yes, you can probably resume your light activities and your baby aspirin or your aspirin. I would say that, as you approach 16 weeks, it'll be time in your pregnancy to do your anatomy ultrasound. And once you do that anatomy ultrasound, they will be able to see if there's any residual blood collected, any residual hematoma remaining. And in that scenario, very simply, just do it again. So if that's what's happening, then no problem. You just leave it be and give it a chance. So as I started to say, we've got a couple of different feeds here. We've got New Life Fertility's Instagram. We've got Randy Fink MD's Instagram. We've got LinkedIn and Facebook and YouTube right here in the middle. And as always, great to see everybody. Hey, would Lovenox, Angela asks, 40 milligrams help if you've had a previous miscarriage due to a subchorionic hemorrhage? Well, that's one of the reasons, Angela, that I tell people maybe it's not a good idea to stay on your Lovenox. So Lovenox, we put people on because there are some folks who will have issues with with blood clotting in the small vessels leading to the placenta. And so in that scenario, Lovenox helps to prevent that. But if you have a hematoma and you are bleeding, then usually we say, well, depending on the size of it, if it's just a little trace amount, then you don't have to do too much there. But if it's more than that, it is probably worthwhile to think about stopping the Lovenox. But if you have that hemorrhage, I would not recommend that you go on Lovenox to try to treat it, because that has not been shown to be effective in making a bruise go away. Because in fact, what it's doing is kind of liquefying that blood. It may actually make that hematoma worse. Hi to Midgie. Thank you for being here. And a special hello to Zenny, who in my dream won the lottery. So we're all keeping our fingers crossed for her and the, I think it was the Powerball. So please buy a Powerball ticket tonight, Zenny, and we'll we'll hope for the best. Hi to Jazzy Poo and Sarah. How long after an ectopic can I transfer again? Well, when you have an ectopic pregnancy or a tubal pregnancy, we typically follow that pregnancy until the beta HCG test turns negative. Once it's negative, then you'll resume normal ovulation and have a period again, and then you can go right ahead. Now, sometimes ectopic pregnancies can be treated with a medication that's known as methotrexate. Methotrexate is a drug that blocks folic acid, and we need folic acid in order for the embryo's spinal column and brain to form properly. So when we are blocking folic acid, then that means we really should give that a little time to work out of our systems. And in that scenario, I usually say about 3 months if you were treated with methotrexate. If that was an ectopic that went away on its own, I would say when you have your next normal period, you can resume your cycle. And if you had surgery, same thing. Once you're recovered and you go back to having a normal period, you can resume another transfer. Let's see. What do you think about going from a fully medicated to a modified natural transfer? So another good question there that comes from Mrs. V. And I would say, I am a fan of the modified natural transfer. What is a natural transfer? Natural transfer is where we let your body take the front seat in terms of making your hormones for embryo transfer. So instead of a medicated cycle where we give you the medication, the estrogen, all the progesterone, we let your body make its own estrogen. We let you ovulate so that when you release that egg, your body will make its own progesterone, and that's a good thing. That's really where the progesterone comes from. So then you don't need to do the progesterone in oil shot, which is of course everyone's least favorite injection in the whole process. If you did a fully medicated cycle and you were unsuccessful with your transfer, and again, I don't like to think about these things as transfer failures. I don't think these are failures. I think these are unsuccessful, certainly, but we always learn something. There is always something to be learned. And so we see how your body responds. We see what happened there. So maybe we can tweak things a little bit differently next time. So please don't think about it as a failure. But if you had an unsuccessful medicated cycle, there is no problem in going to a natural cycle after that. Now, what is a modified natural? A modified natural is where we add a modification. What's the modification? Well, usually we give you some ovulation induction, usually a little letrozole, to make sure that you're going to release an egg, that you're going to produce that egg, and then we give you a trigger shot to release it in a predictable fashion. That's what a modified natural is, and there's no problem going from a medicated cycle to a natural cycle. Erica is here. Thanks for being here, Erica. Kat B says, how bad does your endoadenomyosis need to be before you consider using a surrogate? So, if you were with us last week and you met our nurse practitioner from Dothan, whose name is Jess, Jess was a gestational carrier, and we talked a little bit about being a gestational carrier and about what that's like, what it's like as an experience for the couple, for the family, as well as what it is for her, and what that has to be like to have a baby and then give that baby to the person who has been waiting so long for it. And she was really very articulate with that. I would love to have her on again to talk a little bit more about it. But endometriosis is the process, Kat, where the lining of the uterus that normally sloughs off when we have a period instead works its way up inside and implants inside our pelvis. And it can confuse the way the brain talks to the organs, to the uterus and the ovaries. As it pertains to an embryo transfer, in particular, it can confuse the way the endometrium receives the hormones, and it can create an inflammatory effect that ultimately can block the embryo from implanting. We have a test that we can do specifically for that type of endometriosis. And that's a test that is known as BCL6, or it has a brand name. It's called Receptiva. Now, there are some practices that don't believe in the Receptiva, but the Receptiva has been shown to identify at a particular time of the cycle whether you are positive for the BCL6 marker. And if so, then we recommend treatment. Now, adenomyosis is a little different story. Adenomyosis is when that lining of the uterus, which is a glandular lining, drops down into the muscular part of the uterus, and can have some alterations in the blood flow and in that endometrium itself. The first thing to do is, well, you can still get your eggs. So get your eggs, make your embryos, and then, I say we can figure out what we need to do. So how bad does endometriosis need to be? In most cases, we can treat that endometriosis, suppress it. And the same really holds true for adenomyosis, but the data is very, very clear on what we can do with endometriosis. 60 days worth of suppression is enough to turn the endometriosis off so that it doesn't have an effect on your embryo to implant. So, Kat, I'd say, most of the time we can manage that sort of thing, but having a gestational carrier is certainly an option, particularly for those who have had recurrent implantation failure or recurrent pregnancy losses, that we can't figure out what exactly the reason is. And in that scenario, sometimes we say, gosh, maybe just use your embryo in someone else. Hard decision to make, a complicated decision to make, but that's kind of my feelings about that. Megan says, I had a laparoscopy yesterday to explore endometriosis. It was only on the uterine wall, fortunately. However, the tubes were removed to being very plump, distended, and diseased. Would this be causing poor egg quality and implantation? Well, the answer there is yes. Yes, it absolutely can be, Megan, because if those fallopian tubes contained fluid, that fluid washes back into the uterine cavity and can kill an embryo that's trying to grow. So absolutely, that is a cause, or can be a cause, for implantation failure. So especially since we're talking about IVF, I believe, for you, it tells me that we're not really using the tubes for anything right now. So in that scenario, removing them probably really was the best option. A special hello to Dr. Pina in Miami, who joined. And if you're still there, thanks for being there, as well as Beach Bum 1207. Angela asked, what if I am positive with blood clotting anticardiolipin antibody? Well, yes, in that scenario, Lovenox is recommended. So what you're describing is something that's called the antiphospholipid syndrome. Antiphospholipid syndrome is a condition in the body where portions of your blood want to make blood clots. Now, classically, we see these blood clots as deep vein thrombosis. So that's a big blood clot that forms in the leg, or something that may travel to the lung called a pulmonary embolism. Commonly, this is diagnosed in women who may have had that kind of complication while on a birth control pill. That's one thing that makes us kind of go looking for it. But people with recurrent pregnancy loss can have that same kind of problem. That's usually why we go and test. So my guess is, Angela, you were tested and you're positive for that antiphospholipid antibody syndrome. And in that scenario, the correct treatment is Lovenox. So if you have antiphospholipid antibodies, then by all means, I would say we want you to be on that Lovenox absolutely as much as possible. So even though you develop that subchorionic hematoma, it may be a reason that you'd want to stay. So that's when you have that balancing act between, gosh, what's the Lovenox doing? Is it doing what it's supposed to be doing? It may be it's thinning the blood to the point that you created a little clot or a little hemorrhage or a bruise underneath the placenta. Well, at that point, maybe you want to back off a little bit until it's gone. And certainly then you can think about resuming. That's kind of how that works there. What are your thoughts on continuing levothyroxine in pregnancy when my TSH is now 0.1 after in normal range after taking the medication for 2 months? In general, I would say yes. In your situation, I believe you may have been started on the levothyroxine because there are some practices that want to keep a thyroid level between that TSH level between a 0.5 and a 2.5. Well, there's not good evidence that it makes a difference. So nowadays, here in my practice now, we don't do that anymore. We end up chasing a lot of people and putting a lot of people on thyroid that really don't need to be on it. But if you're at a 0.1 now, that means your thyroid is working plenty fine. In fact, maybe even almost maybe a little too much. So I might suggest thinking about backing off on your thyroid there for sure. Now, I will say that the TSH thyroid activity tends to go up in pregnancy. And so TSH tends to go down. So oftentimes folks who are a little higher on their TSH earlier end up in a much better, kind of much more normal situation. Just one thing to mention about that TSH. The TSH is the measure of the thyroid hormone's function. Thyroid lives here in your neck. But basically, the higher the TSH, the lower the function of the thyroid, and vice versa. The lower the TSH, the higher the function of the thyroid. So if you had a TSH performed and your number was very, very high, that means you have hypothyroid. Your thyroid's working too slow, too sluggish. If conversely, you do that test and your number is very low, then that means you have hyperthyroid and the thyroid's volume knob is turned up a little too much. That's kind of how we look at TSH. Hi to Mrs. Gales, and let's see what we've got here. Sharmila is here. Hi, Sharmila. It's nice to see you, and I wanted to say a personal thank you to your very, very kind words that you sent me last Friday through Instagram. It means the world to me. Thank you very, very much. It's about 20 minutes after the hour. This is Fertility with Fink on New Life Fertility and Randy Fink, MD. We've got Instagrams, we've got LinkedIn, we've got YouTube, we've got Facebook, all manner of ways to answer your questions. So please feel free. Let me know. And if we can't get to them here on the show, email them to me at askfertilitywithfink@firstfertility.com. And we will get to them top of the show next time. Every Tuesday evening, we are here. Victoria says, what is the cause of a 7-week miscarriage on a tested normal day 5 embryo? Well, Victoria, I will tell you that is one of the most frustrating problems that we face. And that is when folks have a tested normal embryo, that is to say a euploid or chromosomally normal embryo, that ends up miscarrying. Because what we know is that most miscarriages occur because of a chromosomal abnormality. So one of the nice reasons to do PGT testing is so that we know that we have a chromosomally normal embryo. So then why do you miscarry anyway? It's a hard question to answer, and there can be a number of different factors. But generally, this is the conversation that I have with folks. I will tell them that, first of all, PGT testing is not perfect. So we're taking a few cells from the outside portion of the embryo to test the chromosomes. It is possible that you can have, so that outside portion of the embryo is what becomes the placenta. You can have a normal placenta while still having an abnormal baby. So it is, and if you saw my post on my Instagram from yesterday, we talked about somebody had asked a question on an interview I was doing, and that was, does, when they do PGT testing, are they taking a piece of your baby? And the answer is no. They're taking a piece of the placenta. Your baby is left alone. So baby is safe. However, the baby part can be abnormal while the placenta is normal. Now, it's not a high risk for that happening, but again, PGT is just not perfect. And so we don't know for sure. Now, what we can suspect is that the chromosomes are, in fact, normal. But what PGT doesn't do is that it doesn't tell us anything about those millions of little biochemical equations, those little reactions happening inside the cells that make up your embryo. And you figure there are probably millions and millions of those little chemical reactions happening every single moment. If any one of those goes wrong, the embryo can stop growing. And that's probably the most common reason that a tested normal embryo will still miscarry. So our hearts go out to you, Victoria. I'm so sorry to hear about your miscarriage, about your loss there. As you know, I always say it's a really cruel thing to go through the process of IVF to make a normal embryo, to make an embryo, a good embryo, a pretty embryo, and then to test it and find out it's normal, and then to transfer it in expecting everything, and then to get your positive pregnancy test, only to then find out that the embryo stops growing. It is not something I wish on anybody, sincerely. OMG Kylie, I like the name. Hello to Jay Serrano, Marcella Schwartz. It's nice to see you. Thank you for being here. A long time no see. Well, Tiana Montez joined us at least for a moment. Miss Montez is a wonderful school teacher in Pueblo, Colorado, and Miss Montez just had a birthday. I would say I think she turned 18, but she may have turned 18 again for the most several-th time, right? But I hope you enjoyed your birthday weekend, and I'm glad to see you here, if in fact you are still here. Hi to Mohai Amal from San Diego. Great to see you. And Maria King, should an isthmos, that's a tough word, an isthmosele repair or a laparoscopy for endometriosis be done before or after an egg retrieval? So let's talk about that, because it's good. What is an isthmosele? I have a real hard time saying the word. Basically, what you're looking at is a defect where a C-section scar was, and that's what an isthmosele is, or isthmosele. And as far as a laparoscopy for endometriosis, my answer to that is no, absolutely not. Do your egg retrieval first, because you can do any kind of repair you need to do on the uterus. The clock does not tick on the uterus the same way as it does on the ovaries. So the clock is really constantly ticking on the ovaries. And because of that, we want to be able to get the eggs out absolutely really as soon as we can. So the earlier you get your eggs, the better off you are. So let's say that you have extensive endometriosis, or let's say that you need to do a complicated repair of the uterus before you do an embryo transfer. Bank your embryos ahead of time. Store them, because they will stay good for you, in theory, forever. Your uterus, you can be menopausal, and we can really probably make your uterus be receptive to an embryo. But once you reach a point after, point of no return, the eggs and the ovaries will be either spent, or probably the DNA in them will not be stable enough to make you an embryo anymore. So my suggestion, Ms. King, is to do your egg retrieval first, then work on the ovaries and the endometriosis and anything else you have after that. What is the ideal embryo banking for 48 years old? Well, I'm not sure what you mean by the ideal embryo banking, but I will say that doing egg retrievals or trying to do IVF at 48 is a very, very tall mountain to climb. And I am never one to be a pessimist. Because Miss Amal, people, miracles can happen. The body is an amazing thing. Our world is an amazing place, and so you just never know. But the odds of being able to successfully retrieve an egg that will be chromosomally or genetically normal to make a genetically normal embryo at 48, the odds are extremely, extremely small. So I always want to have a good conversation with people beforehand so that they know the reality of what they're getting themselves into. And sometimes I would find that it happens that people do well on an egg retrieval, but then when they go to try to make the embryo doesn't grow, and then they come back and they say, "Well, what can you do differently? What can you do to make this one work?" And to be honest with you, we're really fighting the biology there. So that is indeed a tough one. Hey to Chef Blackney, nice to see you. How much tacrolimus do you usually prescribe, and in what part of the cycle should it be taken? So tacrolimus, also known as Prograf, is a medication that is studied to prevent recurrent implantation failure at a dose of 3 milligrams per day. Now, the studied dose was 1.5 milligrams twice a day. 1.5, but the pill comes in a 0.5 and it comes in a 1. So if you're going to take a 1.5 twice a day, you're going to have to fill 2 prescriptions, probably pay 2 copays. The alternative there is to get the 1 milligram pill, or I think it's a capsule, and take that 3 times a day. So 3 milligrams a day in divided dose. Usually it starts, if you're doing a medicated cycle, it starts at the time of progesterone start. And usually we have you continue it through the first trimester. I like you to continue it through the first trimester. If you're doing a natural cycle or a modified natural cycle from the time of your trigger or the time of your ovulation, that's when you start the tacrolimus, and same thing, you continue it through the first trimester. So that has been shown to be a very effective treatment for women with recurrent implantation failure. That is to say, you're making good quality embryos that aren't sticking, and we find that, there could be an immune problem there that's preventing it, and tacrolimus is the treatment to stop that immune problem. So hopefully that answers your question there. Chef, all the best to you. Hi to Nick Betez. Teeny Tina, I like that. Hey, how are you? Thanks for being here tonight. Special hello to Liz Carmen. Cat B says we only have 2 embryos. Both of them are day 3. One is good, one is poor. I'm almost 42. Are there better odds with a young non-endo female? Well, so let me tell you there. So I think we're going back to the question about, does it make sense to think about using a gestational carrier, or what you might call a surrogate? Usually the term I use, surrogate, is for somebody who is providing both the egg with the partner's sperm, and then that embryo goes inside them. But I think we're talking about using your egg to make your embryo, and then placing that embryo either inside you or inside someone else. So, the issue there, Kat, is going to be one of embryo quality. There is nothing wrong with a day 3 embryo. Many practices will not use day 3 embryos because when we grow an embryo to the blastocyst stage, which is going to be typically day 5, but sometimes day 6 and sometimes day 7, when we do that, we know that embryo has a higher probability of being able to get you pregnant. And so when we have a day 3 embryo, we just don't know what that embryo is going to do. Is it going to survive? Would it otherwise survive to the blastocyst stage? And the difference there, going from the cleavage stage embryo, or like a day 3 embryo, to blast, is that it's no longer just a set of cells that are trying to figure out how to divide. It really becomes a little functioning machine, a little metabolic factory, if you will. So that's why a blast has a higher chance of getting you pregnant than does a day 3 embryo. Since these embryos came from you and you're 42, we know that the odds of, well, let's say that you had a blastocyst at 42, the odds would be really a little less than about 5% in an untested blast that would give you a baby. So the question there is not so much one of, is your endometriosis going to stand in the way, but rather is the embryo itself normal? So in your circumstance, I think what I would do is I would do this. If we know that you have endometriosis, I would do the 60 days of suppression, which is either with Lupron or with an oral medication, or Alyssa or Myfembree. The oral medications are a little bit better tolerated, so it's often maybe a better choice. And then put both of your embryos back. I would transfer them both together. That does not increase your risk of multiples because the odds of both of them being normal are not as high as potentially one of them being normal. So you are within the guidelines by transferring two. That's kind of the way I would slice that one, Kat. Hi to E. Romero and Fit and Healthy. Hi, Andre, as always. Nice to see you. Jay Serrano says, I went to my PCP today for what I thought was a pulled muscle in my bicep. Turns out I have a superficial blood clot. I haven't been on IVF meds since my last unsuccessful embryo transfer in November. Well, that's interesting. Now, what you're talking about there, Jay, is a superficial thrombosis. And there is a difference between a superficial thrombosis and what we know of as a deep vein thrombosis. A deep vein thrombosis, or a DVT, typically happens in the deep vessels. And it can happen up here. It often happens in the subclavian, which is kind of underneath the collarbone and down in here. But it sounds like you may have a superficial thrombosis. That typically is not caused by medications. Those superficial things can happen, just like varicose veins can happen in the legs. They often happen really just because they happen. So I don't think that superficial thing, especially if it's something that's new, had anything to do with your transfer meds back from November. But interesting thing there. I'm curious if do you see anything on your skin? Because sometimes with that superficial thrombosis, it looks like a varicose vein, or you might see a little bruise over a vein, and that's not an uncommon happening, just kind of as part of the human condition. So but glad it was nothing more serious there for sure. Have you seen Viagra suppositories helping some women to thicken their linings? I just started on it and it's giving me headaches. Well, not surprising. So Viagra, the way it works is that it dilates blood vessels. What causes a headache? It's a dilation of the blood vessels. And so a headache is not an uncommon side effect of using Viagra. Now, Viagra is used off-label to help with the blood flow that's going to the uterus, thinking that for folks who have a more complicated time thickening their lining for implantation, Viagra is one of the tools that we can use to help get you there. Another common side effect that happens with Viagra is that it changes the way temporarily, within an hour or so after putting it in, is that it can change the way you see color, that your colors kind of look a little funny. And if that happens to you, it is not because you're having a stroke. It's not because something is wrong with you. It really is a side effect of the medication. And the third side effect that's not uncommon is that people get a stuffy nose, is that it can cause, just like it can cause vasocongestion in the genitals, it can cause vasocongestion in the nostrils, and give you a stuffy nose. So yeah. Hey, Angelica. I like that name too. Let's see what we got here. Ariel asks, do you believe there's just, I'm not sure what the question is there. Do you believe there's just us after having a lap surgery, having a frozen transfer? Maybe you want to try to ask that again, Ariel. Do we believe there's just us? Because when you ask that question, I think maybe you're asking about in the universe, is it just us? Could there be other intelligent species out there? But I'm not really sure what that has to do with laparoscopic surgery or frozen transfer. So ask it again, and we'll see what we can do there. Nikki asks, should I transfer 2 day 5s or 1 day 5 and 1 day 6? I have 9 blasts, 6 day 5. And 3 day 6s. So, in my opinion, so first of all, I would want you to follow the guidelines as far as how many embryos to transfer. But assuming that you are okay to do a multiple embryo transfer, we'll just go with that plan. The question is 2 day 5s or a day 5. Oh, pardon me for yawning. You see what you did there? You made me yawn. I've been yawning all day long. I'm sorry about that. Yawning on live television is not cool, man. What I would do really, Nick, is depending on the grades of those embryos. I always recommend that you transfer the best graded embryos. So some people have said, well, I want to put in more than one embryo because I want to make sure, or I want to increase the odds of my getting pregnant. Well, so therefore they say, I'm going to put in one beautiful embryo and I'm going to put in one poorly graded embryo, thinking that somehow those things balance themselves out. They don't. So really the goal from doing an embryo transfer is nothing other than getting pregnant. So I would say pick the 2 best graded embryos. Now, how much does embryo grade really have to do with success? Honestly, it depends on which study you read. So many people will tell you that embryo grading is by and large it's a beauty contest, and in many ways it is. But there are some studies that show us that better graded embryos do perform a little better. What's interesting there is that, and here's the story that I have with it, and if you haven't heard me talk about this before, we all get really tied up, in embryo grading because we've all been to high school. Right. And when you go to high school, you get a grade that tells you where you are relative to everybody else in the class. And that grade says maybe if you get all really, really good grades, you're the valedictorian. You get to give a speech, or you have to give a speech when it comes time for graduation. That puts you better. You're a better student because you got better grades. Grading doesn't necessarily mean the same thing in terms of embryos. Grading was really developed so that in trying to determine whether an embryologist could look through a microscope at certain features in an embryo and try to determine which of the embryos are chromosomally normal based on the features that they see under the microscope or the embryo grade. Well, as it turns out, it's really not the case. It doesn't work. Because if you've done PGT testing yourself, you may have had your most beautiful, perfect, highly graded embryo that has multiple chromosomal abnormalities, while meanwhile your poorest graded embryo is the most normal in the whole bunch, chromosomally speaking. So, but we have to use something, so we look at embryo grading. I would say, your day 5 or day 6, day 5 and day 6 embryos typically perform very, very similarly. A day 7 blastocyst doesn't perform as well. So if it was a choice between a day 5 and 7, I would say day 5 all day long. However, since you're talking about day 5 and day 6 versus 2 day 5s, I would say whatever your best graded embryo is, whether it's a day 5 or day 6, those are the 2 that I would use. What is the use of LDN in pregnancy, and are there any steps to wean off of it? Low-dose naltrexone is something that is used to increase your endorphin levels. And really we use it as part of some immune protocols in order to get pregnant, specifically for embryo transfers. In reality, it really doesn't have a whole lot to do with pregnancy itself. So I think you'd be fine to probably stop it. You really don't have to wean off low dose naltrexone. You can really just stop. Um, there are some people who say, well, why stop it? I mean, it may be helping you. It may be doing something good. It has, in the anti-aging community, low dose naltrexone is something that people use all the time because it helps with, it can potentially help with autoimmune things and pain and things like energy levels and so forth. Um, so people stay on it for a very long time. We don't have any good studies in pregnancy, and the thinking is, well, stay on it because why not? But I think at this point, you probably don't really need it anymore. What is the role of estrogen after a transfer, and is it possible to have too much? Well, so what happens is that the role of estrogen in embryo transfer is to build the lining of the endometrium. And people often ask about, well, what should my level be? Well, the most important thing to know is that it needs to be such that you create a normal endometrium, that your endometrium is greater than 7 millimeters or 6.5, depending on what which measure you like, but call it 7 millimeters. And if it is, the number may not really make so much difference. However, we do stay on it because it helps to maintain that endometrium, even though you've started some progesterone, which is going to take that endometrium and start to compact it, to make it smaller and make it more ready to retain an embryo. So if you've done a natural cycle, then you've really made your own estrogen. And that should have been thick enough. And then you released your egg, and that made your own progesterone. We give you a little progesterone support, but with a vaginal suppository. But in a medicated cycle, you stay on it. We're looking, ideal levels of estradiol are between about 200 and 500, between about 200 and 500, roughly speaking. That's when the outcomes are the best. But let's say that you did a level and it was 800. Would I necessarily cancel your transfer? No, I wouldn't, because plenty of people get pregnant with those kinds of numbers. If I did that number and your number came back as 3,000, would I cancel your transfer? I probably would, because you don't need that much estrogen. That's going to be starting to mess with things. So is there possible to have too much? Well, if it puts you into the range of what we might see with polycystic ovarian syndrome after an egg retrieval, yeah, it can be too much. And if it's too low, then typically it doesn't make your lining thick enough. Let's see what else we got here. Do you think low carb and healthy eating is as good as the carnivore diet? Carnivore is too strict for me. Well, I'll tell you, I am not a carnivore person. Dr. Kiltz is the guru of carnivore, and can talk to you about carnivore like it's a religion, because for him, he believes in it so very, very strongly. In my opinion, the data is not it does not show us that there is any one diet that is the best specifically for fertility. The one thing that all the diets agree on is low carb, because carbs, we know, are pro-inflammatory. Carbs create inflammation in the body, and carbs are what adds weight to us and really can do us some harm. So to the extent that you're able to do a low carb, or to just at least monitor your carbs and keep them as low as you can, that is a good thing. So keto is high fat, moderate protein, and low carb. Really, no carb is like an Atkins diet. And anything that, here's just my personal opinion. And this is not as a scientist, this is as a human. Because again, there are people who will argue till they're blue in the face that I don't know what I'm talking about this. And I do not claim to be an expert on diet, but just like you can't get into a bathtub that's either all hot or all cold, you have to have some mix of the hot and cold in order to be able to sit in that bathtub. So something that is an extreme, like all carnivore, to me is very difficult, both to understand and to embody. And so, therefore, I think a nice mixture, same thing in politics. If you are hardcore all Republican or hardcore all Democrat, well, in reality, some of your the feelings about things may they're going to be pretty polarized, whereas some little combination of all these different thoughts come together to make something that might be a little more palatable. So all on one end of either end of the scale is a difficult thing for me, but low carb I think is a good thing. Do we use InvoCell at our clinic? I know a few women who have had success using it. So we do not use InvoCell. InvoCell is a device that where you place sperm and egg together in a little container that then goes inside the vagina, and is supposed to allow for fertilization to take place. And it's done a little differently than we do with IVF, which is where sperm and egg are introduced in the lab and that embryo is created in the lab. We don't use InvoCell because we have a very, very, very good laboratory. And our laboratory's results can't be trifled with. Our pregnancy rates are extremely high. We have a very strong IVF program and strong laboratory. InvoCell sort of takes IVF and leaves it a little bit more kind of to chance. And so, in my opinion, it's not something I feel comfortable offering because it's expensive still. And I feel like if you're going to spend the money, you should be able to have the very highest kind of outcomes that you could possibly expect. Nikki says, "Oh, so happy you're back live. Thank you." Thanks, Nick. I sure do appreciate that. Let's see here if I missed anybody over here. I think we got those. Hello to Zamanera. I can't say the name. I'm sorry, but Impeccable says, but hello, thank you. Impeccable says, what are your thoughts on Fertilo for women with really low maturity rates? Have you heard of it? Essentially, they only use a few days of medication and then mature eggs in the lab. Okay, so kind of what you're talking about is what's known as in vitro maturation, or IVM. And in that scenario, you are retrieving eggs. You're using some medication to make some eggs, but retrieving those eggs when they are still immature, rather than allowing them to mature in the ovary itself. You mature them in the lab. In principle, it sounds like a good idea. I said impeccable. Thank you. Impeccable. It sounds like a good idea, and I think it ought to be a good thing. The problem is that the science is not there right now to be able to say to have perfected really in vitro maturation. Now, in some programs, if you have an immature egg that we retrieve, those eggs will hold on to them to see what happens the next day. Maybe they do mature, and in that scenario, well, they're pretty close to maturation. I think when we're talking about this IVM here, they're talking about getting them much earlier, and there's just we don't have a lot of science to back it up yet. Hopefully, at some point, there will be we will know a lot more about it, and then it will open doors for folks who have been troubled by maturity rates. Now, there's one other thing that did remind me of that I wanted to talk just a mention of before, because we're talking about embryo grading and whether embryo grading is predictive of whether an embryo is going to be normal or not. And we know that not really, no. Again, they designed this scheme to hopefully be able to look at an embryo and determine whether it would be normal. There is some progress being made on that, and that's with something that's called an embryoscope. So an embryoscope is a device where you do your IVF, you retrieve your eggs, you fertilize the egg, but the entire process then basically happens under a camera. And the camera can think of it as it's taking a series of pictures, but think of it as continuous video of the way that your embryo fertilizes and the way it starts to grow, the way those cells divide. And what happens to the embryo as hopefully it becomes a blastocyst. That's an embryoscope, and it's really fascinating. So when you see these things, I mean, it's amazing. It's amazing what you can learn from that. Um, these things are, my hope is that so they're taking all kinds of data, looking at those embryoscope things, and they are able to determine, or at least they're trying to determine, and using artificial intelligence to say, well, what are the structures, what are the steps, what are the things that are happening in chromosomally normal embryos that correlate with something that you can see under that embryoscope, that microscope that's taking those pictures. So that then, rather than just a static embryo grade that you get at the time it becomes a blastocyst, that you're actually getting to see the embryo grow before your very eyes, and making some predictions about what's going to be normal, given what you see under the embryoscope. That's new science. It's coming along. There are plenty of labs that have embryoscopes, and that's a good thing. We will have one here, I think, starting next month. So love that. I think that's fantastic. And as that science grows, we will really make some big strides towards people. Let's see here. Estrogen was a little low at the time of transfer. They had me increase the estrogen. Now it's over 1,000. That might be a little higher than I would like. And to be honest with you, Shanna, there, if the I think that's okay, because your lining was thick enough. You're now well after the transfer, so I don't think you have to worry too much. Hi to Donna Spicer and Running Girl Training. Very nice to see you here this evening as well. Let's see, we've got about 5 more minutes in the program. 5 minutes till the top of the hour. If I haven't been able to get to your question, please email me at askfertilitywithfink at firstfertility.com. Took me a minute there. I hope you're enjoying yourself this week. We got all kinds of special things coming up in the next couple of weeks. It's graduation time. I do have a son who is graduating from high school, which is really an unbelievable phenomenon. It seems like yesterday, I was rocking him to sleep. And my friend Dan coined a phrase that I think is very cogent, and that is, we don't get to rent them for very long. They're not around for so long, and treasure those memories, treasure those pregnancies, treasure the moments leading up to those pregnancies, because they go by so fast, and life just disappears in the blink of an eye. All right. Well, it looks like that's going to be. Oh, we did have one more question. It is, does L-arginine increase day 3 FSH levels? Not that I'm aware of. So L-arginine I use for embryo transfer. It is something that we should not be using L-arginine for egg quality. It seems like I might have read something about that, but I don't use it for IVF cycles or for fertility in particular, but we use it specifically for embryo transfers. It's one of the 5 supplements that I recommend that you be on for embryo transfer, and that is prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. So now you have it, and congratulations to your son. Thank you. I'm sure I will, God willing, be posting some pictures in the next couple of weeks of a little graduation time. I try not to bother people too much with those personal things, but that one may be worth it, to see him going from babyhood to walking across the stage. Here's one more question. My prenatal has 200 milligrams of DHA. Do I need to add a separate supplement of fish oil? Well, given that you are pregnant now, Rosa, I think that you are fine with that 200. The recommendations for as far as getting pregnant is actually a much higher dose. It's like 850, 900 milligrams of fish oil. But for being pregnant, they are, I think you're fine with that 200 milligrams of DHA. There are 2 forms of fish oil, or omega-3. One's called DHA, and the other is called EPA. Sometimes you can get a combination of those, but I think you're okay there. Rosa, and can I repeat the list of supplements for transfer? Sure. Prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. Those are your lists, and I'm happy to send that to you if you just message me. Looks like we are going to be out of time for tonight. I'm so happy that you all are able to join me here on Tuesday evenings, and I hope you'll be back next Tuesday at 5 o'clock Central Time. Until then, gosh, please remember what I always say, that this fertility business is not the book of your life. It is merely a chapter. And what are we doing? We are here to try to rewrite it together. So until next time, one foot forward, one foot in front of the other, every day with love, every day with hope, and every day with the knowledge that tomorrow brings a whole new set of adventures. Until next week, I'm Dr. Randy Fink in Pensacola, Florida. Thanks for being here, and good night.